stabilizing epidemics or even great success in decreasing the new infections in their countries. HIV in the Philippines increased fivefold between 2007 and 2009, and about 1/3 of new infections are among the 15 to 24-year-olds. While overall caseload in the Philippines is comparatively low, the trajectory is really alarming. Prevalence has breached 5% among risk groups in selected sites, and among IDUs it breached 50% in one city. The other issue is key affected populations are young. We estimate about 55 to 65% of key affected populations, which are MSM, sex workers, and HIV drug users, are 15 to 24 years of age, according to the DOH surveillance. And about 4 to 14% of key affected populations are between 15 and 17. According to the same data set, correct knowledge among the under 18-year-old key affected population on modes of transmission and prevention is 18 to 24% only, while for adult key affected population this is 31 to 46%, which is also not great, but at least for the adults it's substantially higher than for the under 18-year-olds. Literally 0 to 5% of the under 18-year-old key affected population ever had an HIV test, which is 24% among adult key affected population. This points to the fact that even if they are at risk, young key affected population are currently not being reached by services. The ICAAP response at national level focuses on data, policy, strategy, and tools. So the previous slides reflect the inclusion of the 15 to 17-year-old key affected population in the DOH HIV surveillance since 2009. This was included starting 2009 and has been institutionalized, reflected in the fact that 2011 also included this young age group, and the next one is planned for 2013. A national strategy framework has been developed and finalized to streamline the national and local response for children, young people, and HIV. In there, the focus on young key affected populations and prevention is the key strategy outlined in the strategy framework, and this has been included into the National Plan on AIDS, ranging from 2011 to 2016. And then, based on previous peer education reviews, a national curriculum and tools were developed for multi-session structured ICAAP peer education with referral, and I'll talk a bit more about this in my next slide. UNICEF support was largely on advocacy and technical assistance on the need for age disaggregated data, including for the younger age groups, the strategy framework, and the curriculum and tools development. So I'll give you two examples of what has been tried at local level. One is the formal peer education with referral, which tries to address the gap that ICAAP are not reached with youth-friendly services. The objective of this intervention is to build skills for risk reduction, to influence social norms, and to support referrals to health and social work services. The focus is mainly on demonstration or, sort of a learning project rather than scale at the moment. How it's being done, the ICAAP peer educators run 6 standardized sessions and support referral in 5 cities in a collaboration between the local government units and the civil societies. Operations research